Thanks, Mike. Good morning. So arthritis in this country has really become almost epidemic. More people they're living longer, they're staying more active for a longer period of time, they're more active from a younger age. So really 30–40% of our population is going to be affected with arthritis by 2030. At the same time, really only 10% of the population currently seeks treatment, so we're certainly going to see a lot more of these patients presenting to us in the future. And it's been shown in studies to be second only to cardiovascular disease in producing chronic disability that can directly impact the quality of life and can be the #1 cause of decreased work performance. So certainly can have significant effects on quality of life, but also work status. In biomechanics, just briefly, the card is definitely different in the ankle. This was mentioned the other day. It's thinner, it's stiffer, and you have 3 times the contact forces going through the ankles compared to the knee, but only 1/3 the surface area. And so certainly with any types of regular activities, daily living, with weight bearing, especially stairs, any type of high impact activities, the ankle is really feeling it. And so the demographics of patients that are suffering from ankle arthritis compared to knee and hip or non-impact joints such as the shoulder is very different. So the patients with ankle arthritis are typically younger, and it's typically etiology is post-traumatic, really 70%, whereas in the knee and hip, it's 85% degenerative arthritis and maybe only 5% post-traumatic. As we discussed the other day, ankle sprains, just a single ankle sprain is the most common injury that presents in the emergency room, and anywhere from 20–40% of these patients can still have mechanical instability, and over time this can lead to arthritic changes as well. So we see an increasing prevalence of severe ankle injuries, over 50,000 new cases of ankle arthritis every year, and Mark Glazebrook did this study which showed again severe physical disability and poor quality of life with the outcomes similar to some of these other diseases that we see here. So Mike has already reviewed this, that really the gold standard for end-stage arthritis in your young active population is a fusion, and the more modern techniques have led to a significant increase in the union rate compared to historical studies. And of course you want to obtain the correct plantar position for the foot. But there have been problems historically, as Mike had alluded to, the non-union rate, which was a lot of this relative to the internal fixation, but also certainly the stiffness, the decreased range of motion, the transfer stresses and arthritis of the periarticular joints around the ankle, and sometimes patients with persistent pain despite union. And so there's been a lot of trend and kind of revisiting the ankle replacement. We'll talk about that later, but also trying to find ways to potentially improve the recovery and the rapidity of recovery for a standard ankle fusion. So some of the disadvantages of doing an open fusion include extensive soft tissue dissection. So by having to expose this subperiosteally, you're really harming the periarticular blood supply. Patients can have infection because of these soft tissue issues, certainly wound healing problems. You have to delay the weight bearing, typically 10 to 12 weeks, and so you have a slower recovery. And so, as I had mentioned the other day, the trends over the last 20 years have been toward more minimally invasive procedures. We have much more reliable arthroscopic shoulder techniques. Certainly we're all getting much more comfortable arthroscopic procedures in the ankle. We also have better image guidance right now, and certainly percutaneous fracture plating and stabilization techniques in other parts of the body as well. So we've learned to focus more on preservation of the surrounding soft tissues, as well as reducing some of the post-operative pain. There's a trend toward shorter hospital stays and certainly increasing outpatient procedures. So some of the advantages of arthroscopic fusions compared to open can be some reduced morbidity. We can minimize the soft tissue concerns, again, by protecting that periarticular blood supply, potentially lead to more rapid fusion without the soft tissue problems, potentially expand the scope of fusion to patients that otherwise would not be good candidates because of their soft tissues, reduce blood loss, so patients even potentially with bleeding disorders might be much better candidates for this procedure, and certainly reduce hospitalization time and more rapid fusion rates and mobilization, potentially reducing some of the stiffness in the other surrounding joints, such as the subtalar joint, by getting these patients a quicker recovery. So arthroscopic ankle arthrodesis has been described since 1983. Schneider was the first one to describe it. And certainly over the last 30 years, we have much more improved instrumentation as well as experience with arthroscopic procedures in the ankle. And so we've seen a large increase in the arthroscopic compared to open fusion rates. And Terrell last year looked at a study over his last 5 years and found a faster time to union, earlier return to mobilization, decreased complications, reduced postoperative pain, and shorter hospital stays. He felt that it wasn't indicated for severe deformities, and the majority of fusions are still done open, but as you can see this graphic here over the last 5 years in his study till 2009, you have an increasing trend toward doing these procedures arthroscopically as compared to open. So the indications for arthroscopic fusion, again, some of these are similar for open fusion: mechanical pain with all weight-bearing activities, failure of conservative treatment, no active infections, minimal preoperative bone defects, minimal to mild correctable deformity in the coronal plane, and moderate deformities that are correctable to neutral if you do have a stress fluoroscopic examination. And contraindications would be an irreducible varus or valgus, significant bone loss, previous attempts at fusion, so it's not indicated for revision procedures, and relative contraindications would be broad-based talar AVN and history of septic arthritis. So the setup, I use a large scope, 4mm scope, which I think it's easier for visualization. I use this 30-degree arthroscope typically, but I have the 70-degree available, which can sometimes help me visualize posteriorly, make sure that the cartilage is removed. Initially, sometimes these joints are really tight, so I also have the small joint scope ready. I can start out with the small joint scope, and then as I open up the joint, I can move to the 4mm. I do have the fluoroscopy in the room, which helps me with my guide pin hardware positioning. I have a lot of angulated small joint instruments, such as you can see the ring curettes on the top, and there's certain the companies that have a lot of these angled ring curettes are very helpful with the cartilage removal, and the pituitary rongeur, similar to as Michael showed with the open fusion, to help remove the debris. And then, of course, you have your large cannulated screws for internal fixation and potentially bone graft of your choice. I position the patient supine. I have bumps again under the hip, but also the knee and the ankle. I let the ankle hang free. We usually do a popliteal and saphenous regional anesthesia, and this has been shown in the literature to increase patient satisfaction, decrease patients' postoperative pain and need for narcotics, and of course decrease their length of stay. And this is, of course, an outpatient procedure. I always mark out the neurovascular structures that I described before, and use your standard portals. I typically do not have to use a posterior lateral portal. I insufflate the joint with saline, I distend it, and before I make my portals, I usually put the 18-gauge needle into my anterior lateral portal, and I want to make sure that it's appropriately positioned so that I can really swing it along the ankle joint, especially into the lateral gutter when it's facing directly posteriorly. You can do this through gravity inflow, otherwise the pump typically between 50 to 80 millimeters of pressure. I do put epi in my solution, and then I use non-invasive distraction, as you can see here. So I tried a bunch of the different holders, and they're always falling off the side of the bed, and so I just use this. I take a Coban, I wrap it around the ankle above the joint and then around the foot, and then I wrap it around sterilely around my back, and I can lean back and obtain enough distraction for the procedure. And then I do my standard arthroscopic examination. Systematically, I like to remove all the remaining cartilage. So I have aggressive shavers so that we can do it quicker, typically a 4 or 5 millimeter full radius resector. And then I remove the anterior osteophytes first, so I do a chilectomy to open up the joint a little bit. I tend to start on the talus first, so I work from front to back. And again, the ring and angle curettes are very helpful, especially posteriorly. Once I've done that, again, your joint space is opened up even further now, and then I go to the plafond and I work from back to front. And again, you definitely want to make sure that you clear that anterior lip. And then finally, I'll move to the medial gutter and I'll debride that. Sometimes I do use a small burr, so I have a 4 millimeter burr and a 2 millimeter burr available in the room. I usually do not debride the talofibular articulation except if they have a pre-existing lateral compression or if I'm correcting a mild to moderate varus deformity. You want to make sure, of course, that it's not just about doing a procedure through the scope. You still have to do the procedure correctly, and so you have to prepare the bone surfaces properly. You want to get down and remove just a minimal amount of subchondral bone to expose the bleeding surfaces. Again, you can see these curved curettes are very helpful to get to the back. You can use an oval 4 millimeter burr. It's a little bit easier to create flat surfaces with the oval burr as compared to the spherical burr. And you can do these what's called spot welding, where you kind of make indentations into the bone. Typically, I do a suction test, so I'll stop the inflow, I put the suction on, and you can see the bleeding bone coming through the cancel surfaces. You want to try and maintain the joint contours, so you're not trying to create flat on flat, but you want to be able to reduce it. And again, as Mike mentioned, you want to be able to make sure that the talus is under the tibia. And then if you see any cysts, I do curette these, and then you can add the bone graft through the portals, as I mentioned a second. And then once the surfaces are complete, I do fenestrate the surfaces. I usually use a 2 or 2.5 drill bit, and I do that just through the regular sleeve that I can put through the portals medially and laterally. Then you reduce the ankle neutral position the same way as you would for an open fusion, and you perform your fusion with solid internal fixation. It's described in literature 2 or 3 screws. I tend to like 3 screws. Typically, I check my alignment before I put in the pins. I get in alignment, I release the traction at this point, and then I put my pins across for the placement. And I tend to, again, use 3 screws, and I place it the same way that Michael described. So medial, the home run screw posteriorly, and then my anterior lateral screw. And I do put these slightly anterior angulation to get a little bit better compression. It also gives me much more talus for purchase, so I don't sneak into the subtalar joint. And then routinely I do use a bone graft. I use typically crushed cancellous chips that I mix with some type of bone marrow aspirate, and I can inject this usually, again, through the portals. Just through a drill sleeve I can inject it through there, or I can make my incision a little bit bigger. If I have any type of deformity, I can also put a laminar spreader through one of the portal sites and help with my correction of deformity. And then in high-risk patients, again, you can expand your indications for fusion in your high-risk patients, such as your smokers, and I do use a bone stimulator post-operatively to try and help augment my fusion, enhance the consolidation. So post-operatively, I keep the patients still non-weight bearing 2-3 weeks in a cast. I put them in a boot at the 2-week mark. They're still non-weight bearing really for 6 weeks, and at 6 weeks I really let them progress to full weight bearing, whereas in open fusion I typically don't do that until 10 to 12 weeks. If we do have to remove hardware, I've not had to do this, but if you do, then I would recommend not doing this before 6 months. When is the ankle going to be fused? Typically, it's when the patient's clinically stable, but these patients arthroscopically really fuse significantly quicker, I found, in the appropriate patient. So it's really when they're painless. Sometimes you won't see that X-ray evidence of fusion for maybe 4 to 6 months, but typically we know they're fused really by 10 to 12 weeks. The results in the literature have shown high rates of fusion. Again, this is comparable to the open procedure, even up to 100% union you can see here. Gugulius looked at doing this procedure arthroscopically for patients with greater coronal plane deformity up to 45 degrees, and he still found 97.4% fusion at 12.5 weeks. He found that with more amount of alignment, he was doing a lot of correction through the joint itself, and so he was excising bone to try and achieve congruency of his joint surfaces, and so he would remove more medially in the valgus deformity, more laterally the varus deformity, and he only had 9% hardware removal. Meyerson historically also comparing arthroscopic versus open, again 94% fusion in the arthroscopic group and significantly more rapid union at only 8.7 weeks he described, and felt that it was very successful with minimal deformity, and O'Brien found similar results in his study. More recently, Townsend last year commented on 30 patients. The open procedure was done with a transfibular approach, and found that these patients could begin progressive weight bearing at 6 weeks, found more rapid recovery in the arthroscopic group with similar low rates of complications, similar OR time, and he was also able to describe correcting deformity in both groups. There's no significant differences in the alignment between the two groups, and he found that the arthroscopic patients had better outcomes at 1 and 2 year follow-up. They found that there was a minimum degree of soft tissue envelope disruption with the arthroscopic arthrodesis. So again, patients that you're concerned about the soft tissues, this could be a great option for you. We could reduce the degree of permanent functional impairment of the joints because of the more rapid recovery early on. So they had better subtalar range of motion because theoretically you could move that joint quicker and earlier. And that the arthroscopic also allowed more rapid activation of the bone healing cascade, potentially because there was no disruption of the periarticular blood supply. So these patients had an earlier functional improvement. And again, he felt that coronal plane deformity was not a contraindication to this procedure. So conclusions, ankle arthritis is much more frequent. People are more active at a younger age. People are living longer, so we're going to see this much more often. Ankle fusion is still the gold standard in our young, active, high-demand patients, but historically there have been some downsides to doing this procedure. And potentially doing it through the scope can help us with some of this. There's a trend now in general toward minimally invasive procedures. We have now more experience doing these procedures in the ankle through the scope. We have improved instrumentation to help us with the debridement of the joint. We've noticed in the literature that there are high fusion rates comparable to an open procedure but lower complications. We can potentially expand this procedure to people that otherwise might not be indicated, such as smokers or patients with poor soft tissues. We're noticing a short time to union, potentially more rapid recovery early on, better range of motion in the periarticular joints as well. Thank you.